want to thank the organizing committee and Fabrizio and colleagues for inviting me to come to Brasilia to give some talks. Unfortunately, I was unable to attend, so I will be taping my talk. So I want to say greetings from MD Anderson. So my first talk would be on pseudoprogression and post-treatment changes. And I have no relevant financial disclosures. So with the introduction of different and new adjunctive chemotherapies for glioblastoma, we have new and different imaging findings both within the tumoral region and when you're looking at post-surgical patients in the pericavitary region. And these pericavitary parenchymal changes can mimic tumor recurrence or progression, or can mimic tumor response, known as pseudoprogression and pseudoresponse respectively, and I'll be going into this in more detail. These are two opposing phenomena and emphasize that enhancement itself is not a true measure of tumor activity, but only reflective of disruption of the blood-brain barrier or normalization of the blood-brain barrier in the case of pseudoprogression and pseudoresponse respectively. So it's important that we know what these changes are and identify them for accurate interpretation, both for the radiologist as well for the treating clinician. So what I'm going to do here is review the imaging findings that occur post-surgery with radiation and chemotherapy, specifically in GBM patients, and define and demonstrate using some of the images the post-treatment conventional and advanced MRI and PET findings that we see both in pseudoprogression, pseudoresponse, and recurrent tumor. And we're going to discuss some of the utility of using advanced MRI techniques such as diffusion, perfusion, and spectroscopy, as well as molecular imaging such as PET in differentiating pseudoprogression from true changes. So the standard of care in a GBM de novo is surgical resection, radiation, and chemotherapy, with temozolomide being the chemotherapeutic standard of care that we use. When we do have GBM recurrence or progressive disease, we use multiple different types. We could use temozolomide as well as Avastin, which is a VEGF inhibitor, and this is a very common something that we use in patients with recurrent and progressive disease in GBM. So this is just demonstrating conventional MRI. We're all aware of these. Enhancing lesion. This is in the left temporal lobe. And we have another lesion in the same patient in the left thalamus. And that enhances as well, although to a lesser extent, and this is just demonstrated here. When looking at the diffusion imaging, we find that in the area of the left thalamus, in the posterior or dorsal aspect of the left thalamus, we see areas of low intensity on the ADC map, and this is consistent with restricted diffusion, which can be seen in patients with high nuclear to cytoplasm ratio and those with increased cell packing or cellular density from tumor, as in this case. And this is just demonstrating in the area of contrast enhancement, this area of restricted diffusion. On perfusion, we can see elevated perfusion, and this is a DSC seeing on the far left, and on the middle we have a dynamic contrast enhancement, and on the right we have a arterial spin labeling. And this is just demonstrating that there is increased perfusion corresponding to that left temporal enhancing lesion. Looking at the left thalamic lesion, again, we see that there is some increase in perfusion, although not to the extent we were seeing on the left temporal lobe. And again, we're seeing that if we look at the spectroscopy on the lower right, we're seeing that there's elevated choline to creatinine and decrease in the NAA peak. So what are some of the post-treatment changes? I wanted to show you just what a tumor, treatment-naive tumor was before surgical and chemoradiation. But if we look at the post-treatment changes, we can divide them into basically three stages: acute, subacute, and chronic. In the acute, you have the surgical changes, such as surgically induced enhancement, acute radiation changes. In the subacute, we also have subacute radiation changes, and then we have this new phenomenon that we are all aware of or becoming aware of, which is pseudoprogression and pseudoresponse, which I'll focus the majority of the talk on, as well as chronically, we have late necrosis and chronic radiation changes, and this late necrosis is usually due to radiation necrosis. So this is an example of post-surgical changes in the acute setting. So you have a patient status post-resection of left temporal lobe tumor, and we have areas, as you see, of linear enhancement, and this is surgical induced enhancement. It's nice, linear, and we see that there is no evidence of restricted diffusion on follow-up, although previously there was some restricted diffusion corresponding to peri-operative ischemia. When we're looking at acute post-radiation changes, this is a case of radiation necrosis, and this is a 49-year-old male patient with a right temporal GBM. And we're seeing here that there's an enhancing mass in the area of the previous resection. And we see here that perfusion and spectroscopy do not show any increase in perfusion or a metabolic metabolite signature of increased choline to creatinine and decreased NAA. As a matter of fact, what we're seeing there on the far right is a large lactate peak. So these findings are consistent with necrosis, and in this specific setting, radiation necrosis. When looking at pseudoprogression and pseudoresponse, this is a very interesting phenomenon that has become more relevant as we have new chemotherapeutics coming into our daily radiological assessments. For pseudoprogression, I'll go through it, and pseudoresponse, and these are treatment-related changes to whether it be chemotherapy or radiation therapy. And to differentiate the two, these are actually two opposing phenomenon. And so pseudoprogression and pseudoresponse are diagnostic dilemmas and have clinical implications. So in the case of pseudoprogression, if we fail to correctly identify pseudoprogression, in other words, that we are thinking that the patient has recurrent tumor, although the patient does not have recurrent tumor, this can lead to premature discontinuation of an effective adjunct therapeutic, or can lead to re-resection because we think the patient has progressed, when the patient is actually in pseudoprogression and probably responding quite well. In pseudoresponse, on the other hand, if we fail to correctly identify this phenomenon, this can result in the patient continuing to be on the therapeutic despite the patient has true treatment failure. In other words, is failing the treatment. And when looking at clinical trials, we can falsely attribute a high response rate to this therapy that is actually ineffective. So taking it first, pseudoprogression, it's a treatment-related change, and what we're finding is increase in contrast enhancement and edema on MRI without true tumor progression. This usually occurs within the first 3 to 6 months and subsequently stabilizes or decreases. And it usually goes away without treatment, or sometimes progresses to radiation necrosis. So what are some of the risk factors? Well, concurrent chemoradiation, 20 to 30% of patients on temozolomide and on concurrent chemoradiation with temozolomide experience some amount of pseudoprogression. Patients having chemotherapeutic wafers, such as gliadil wafers, high-dose radiation, as well as those having a positive methylation of the MGMT promoter gene. More recently, the immunotherapy cohort of patients, we are finding that they have a very robust response in terms of increased contrast enhancement and edema, and they are actually responding to the therapy, but that looks like a florid progression, and so this is becoming more prominent as we are progress to the immunotherapeutics going forward with the clinical trials. So the pathology, so we have a pronounced local tissue reaction with a large inflammatory component, endothelial injury and disruption of the blood-brain barrier. And this is just seen here, and actually I'm going to give credit to my colleague, Dr. Roy Riascos, who is now in University of Texas, who did this drawing for me. And it's just demonstrating that with chemoradiation, you have damage to the endothelial, and thus you have the increase in edema, as well as disruption of the blood-brain barrier and contrast enhancement. So the mechanism of action of temozolomide, it is an alkylating agent. And what we're finding is that inhibition of DNA and cellular replication and ultimately apoptosis occurs. When we look at the MRI, and so this is a patient with status post left temporal lobe tumor resection on temozolomide and radiation for GBM treatment. And what we're seeing here is some small amount of nodular enhancement surrounding the resection cavity margin. There is no evidence for restricted diffusion, no increase in perfusion as defined on dynamic susceptibility contrast by relative CBV, and MR spectroscopy shows the large lactate peak, and all the other metabolites are decreased. So this is a very typical and classical case of pseudoprogression rather than true tumor progression. This is another patient here with a right temporal lobe temporal lobe tumor that was resected, and we have these two nodular foci of enhancement along the posterior border of the resection cavity margin. And when we look at the diffusion, there's no evidence for restricted diffusion, no increase in perfusion, and this is demonstrated by arterial spin labeling. And there is no evidence for metabolic activity on our FDG PET. So again, more findings, classical, typical example of a patient with pseudoprogression, not recurrent tumor. So if you look at some of the imaging biomarkers that we could use is the diffusion, the ADC. And patients who have decreased ADC suggest that there is true tumor progression. And those that have an increase in ADC, not only do they have a more favorable response, but it's less likely to be a recurrent tumor, as well as perfusion. We have decreased perfusion in those patients with pseudo-response. Patients with MGMT, very important. If your clinician tells you about MGMT promoter methylation, those patients have an increased pseudoprogression as well as increase in patient response rate. So they actually are responding better, although they do have pseudoprogression. And this is again demonstrating another patient, again over time with pseudoprogression, increase in nodular enhancement surrounding the left frontal resection cavity bed, no evidence of restricted diffusion, no evidence of increased perfusion. And we see here that there's collapse of the cavity and continued absence of restricted diffusion and increased perfusion. And again, this was consistent with pseudoprogression. This is demonstrating gliadale wafers. So these are wafers impregnated with carmustin or BCNU. And again, what we're seeing here are patients, when they get these wafers placed within the cavity at the time of surgery, you can have a reaction as well. And this is just demonstrated here by areas of nodular enhancement surrounding the resection cavity bed, which subsequently subsides, and there's no evidence for increased perfusion. Recurrence, on the other hand, would either it would increase over time. In this case, it disappeared. So again, another case of pseudoprogression. So with gliadale wafers, a lot of times we use the same kind of imaging biomarkers, and we look at areas of decrease in perfusion, as well as stability and decrease in restricted diffusion and contrast enhancement and edema. Pseudo-response is the opposite phenomenon, and that's a decrease in contrast enhancement of the brain tumor, specifically GBM on MRI, without a true decrease in tumor activity. So in other words, pseudo-response means that the patient is actually progressing and not responding, although there is that decrease in contrast enhancement. So the pathophysiology, it's usually seen in anti-angiogenic therapy, and we can divide it into two phases. First phase is due to normalization of the blood-brain barrier and permeability of the vessels, and there we see a rapid decrease in contrast enhancement on MRI, and that usually occurs within 24 hours. The second phase is the more chronic phase, in which you have glioma cells which adjust to that decrease in angiogenesis and become more infiltrative and actually more aggressive. So in this case, you have an increase in flare hyperintensity without a concomitant or simultaneous increase in contrast enhancement. So I'm going to demonstrate it to you here. This is a typical case of pseudo-response with Avastin. And Avastin is one of the major causes for pseudo-response. So again, I give credit to my colleague, Dr. Roy Riascos in UT, across the street, who has done these depictions for me. So you have this tumor, and it's you have the VEGF that is being given out by the tumor. And we see here that it glues on to the VEGF receptor and results in increase in angiogenesis. And it continues to grow. More VEGF is let out of the tumor and goes to the VEGF receptor and again stimulates angiogenesis. Then when we give Avastin, this actually inhibits, it's an antibody and inhibits the sticking of VEGF to the VEGF receptor. And what we have is decrease in angiogenesis and decrease in contrast enhancement. So Avastin decreases the area of contrast enhancement within the first 24 hours, and this is normalization of the blood vessels. As I mentioned to you before, this is the first pseudo-response that you can see. And there's that decrease in contrast enhancement. Then glioblastoma undergoes adaptational changes, so transcriptional and adaptational changes at the level of the genes, and these new cells are infiltrative cells and survive under hypoxic conditions. So again, you have decrease in contrast enhancement, but you have this increase in flare reflecting the invasive tumor. And so you're going to have these invasive cells that are actually more aggressive and portend actually a very bad prognosis. So with pseudo-response, again, we have our ADC, our relative CBV, our perfusion, and our PET. And ADC values can be used as an early predictor for treatment failure, and suggesting that an increase in non-enhancing infiltrative cellular tumor growth, a decrease in ADC or restricted diffusion in the non-enhancing parts of the lesion suggests progressive disease, even though it's showing a decrease in the volume of contrast enhancement of the lesion. So these are all things that we can use. Similar to recurrent tumor and pseudo-response, you would have findings more reflective on the advanced imaging techniques of recurrent tumor. And so this is another case, and this is demonstrating a patient with a right parietal lobe contrast-enhancing tumor, a lot of T2 flare hyperintensity reflecting edema/invasion, and a small focus of restricted diffusion in the splenium of the corpus callosum on the right. And what you're seeing here, a decrease in ADC on the far image on the far right. Patient underwent Avastin treatment, and you see here that there's a decrease in contrast enhancement of that right parietal corpus callosum lesion. However, over time, you're seeing that there's increased flare. This has creeped up into the bilateral, right greater than left, corona radiata and frontal lobe region, and the area of restricted diffusion has increased. So this is consistent with pseudo-response. Even though there's less contrast enhancement, there's actually progressive disease because the tumor has become more infiltrative. One of the important things to note is that we have changed from the McDonald to the Raynaud criteria when we're looking at these patients. So while in the McDonald criteria, we would have said that the patient had partial response because the contrast enhancement portion was decreased, according to Raynaud, we not only look at the area of contrast enhancement, but of flare. And because the flare has increased, this is consistent with tumor progression, and it is a phenomenon known as pseudo-response. And this is a patient with pseudoprogression, again, highlighting the fact that we have changed from the McDonald criteria to the Raynaud criteria. And if we look at the McDonald criteria, we would diagnose this patient with progression, as McDonald looks at the contrast enhancement portion of the tumor, and if it's increased, that means it's progressed. In the Raynaud criteria, we find that within the first 12 weeks after you complete your chemoradiation, pseudoprogression is most prevalent, and so we cannot diagnose the patient with progression unless either of the following. It is beyond the high dose region, or the 80% isodense line, or if there is pathological confirmation of progressive disease. So in these cases, you usually follow these patients and see if it is stable or decreased. Moving on to the chronic post-radiation changes, this is a patient, 59-year-old male patient, status post-tumor resection, radiation treatment, and this axial flare image demonstrates bifrontal hyperintensity, quite symmetrically, as well as volume loss. And we see on diffusion tensor imaging that there is disruption of the bifrontal white matter tracts, suggesting injury of the tracts at the port of the radiation. So this is just chronic post-radiation changes. So in summary, new chemotherapeutics have triggered a variety and a cascade of unique and recently defined imaging appearance that we as radiologists must be aware of. And we must have sufficient knowledge not only to diagnose and avoid imaging pitfalls and such a pseudoresponse and pseudoprogression, but we must be able to determine is the patient having recurrent tumor, is it pseudoprogression, is it pseudoresponse, and we must be aware of the advanced MRI techniques and the PET imaging that can be helpful to differentiate these. Potential MRI biomarkers can help predict response versus non-response to therapy, especially when you're talking about advanced imaging, and create a more personalized chemotherapeutic paradigm for each patient. I think future directions that we have to go through is looking at tumor heterogeneity that we know leads to differential treatment responses, and understand better the gliomogenesis and the landscape of chemotherapeutics, and why do we have some patients having pseudoprogression and others not, as well as pseudoresponse and others not. And we must be able to tailor the therapy based not only on genetic but imaging biomarkers, and that will be a major step towards personalized medicine. We should also be looking and contributing information to predict response and non-response to treatment. And that will allow for better understanding of when to continue on a treatment that is working, or when to make treatment changes on a treatment that is not working, and doing this early on during therapy. I added this in because one of the important features, one of the important new upcoming methods of imaging analysis is called radiomic analysis, and that is extraction of high throughput imaging features on a pixel and voxel level. And the question always remains is, at the time when there is a question of pseudoprogression or even pseudoresponse versus true progression, how can we differentiate these pseudoprogression from true progression? So we've done a small cohort of our MD Anderson patients looking at those with pseudoprogression and true progression, and found that radiomic analysis or feature extraction using texture analysis, we might be able to distinctly identify those patients with true progression versus pseudoprogression, and that's just shown here. It needs a lot of work, but this is the beginning. These are some of the references, and I thank you very much, and I want to acknowledge my lab, and I want to acknowledge the committee and all that went in this to inviting me, and I thank you very much.